Good afternoon, everyone. My name is Dr. Frederick Van Gestel, and today I will be sharing with you some of the research that we're currently performing at the University Hospital in Brussels on the use of augmented reality during surgery. Now, to fully grasp the potential and the added value that augmented reality guidance could bring to surgery, we should first look back at how the current surgical navigation is performed nowadays. First of all, quite obvious, the surgeon starts off with his anatomical knowledge. It's obvious, but still key. On top of that, he is able to use what we see on the right with the current navigational systems, a way of localizing himself in the 3D space inside of the patient based on 2D scans he can see on a screen. And this is how it's performed in practice. So the surgeon, using a pointer device, is able to localize himself on the scans, preoperative scans of the patient where he is pointing at. Now, this requires him to look away from the patient to a screen. And on top of that, he's looking at these 2D images. Sometimes there's a 3D image provided, but still all this information needs to be put together and then needs to be transposed to the patient, which is a quite mentally demanding task. On top of that, these devices are often bulky and expensive, taking up a lot of room in the OR. Again, the surgeon, as we can see, is looking away from his patient to a screen, dissociating his headspace from the patient and causing potentially dangerous situations. And again, the mental load is not to be underestimated. This results in several limitations. For example, the size of these devices do not allow it to go outside of the OR. So for procedures that are often performed outside of the OR, such as intracranial drain placement, which is often done in the emergency room or the intensive care unit, this is not possible to do navigation. So we use anatomical landmarks, as we can see here, which are not patient specific, but rather general and based on literature. These are used to place these drains in the ventricular spaces of the patient. Now, without guidance, the accuracy of optimal placement is about 80%. You might say, okay, 80% is not that bad, but that also means that 1 in 5 drains is not in its optimal location. And this is inside of a brain of a patient. So here we see a clear benefit or an added value that could be brought by navigation. On the other hand, we have more complex procedures in the spine that require supplementary imaging during the surgery for the navigation to work. And this supplementary imaging is just not always available. And again, I cannot stress this enough, the ergonomics and the mental load, the mental burden that is put on the surgeon for transposing all this information is not to be underestimated. Back in 2015, Microsoft released their HoloLens to the market. The HoloLens we all know, which is able through their inherent sensors and processing capacities to provide the user with an augmented reality overlay on top of the real world. And surgeons at the University Hospital in Brussels, we saw this and we said, we want this. We want to use this in the OR to see on top of the patient the scans that we performed beforehand, so that we don't have to look away again and still process all the imaging. So we reached out to the engineers of the University of Brussels with the question, can we develop this? So we started working together side by side so that as soon as the engineers had developed something, we as clinicians could immediately test and validate it to make sure that in the end we would be developing something that is clinically relevant. Because all of us, we saw the possibilities of this technology, not only in surgery, but in medicine in general. For the patient, possibly resulting in less invasive and safer procedures. For the physician, possibly reducing his operative time, and also for starting physicians and even students, granting them training possibilities and possibly faster learning curves. And then for the hospital and the society in general, these devices had a significantly decreased cost versus the current navigational systems. On top of that, there's also the possibility for shared experiences over longer distances. So together with the engineers, we set up the SARA project, the Surgical Augmented Reality Assistance. And this is a project that is being performed by both academia and industry partners and is focused on neurosurgery and orthopedic surgery. As you can see in the following fragment made by the RTBF last year, this technology could then provide assistance for the surgeon during a procedure. In this case, it would be the resection of a tumor to localize a tumor and the surrounding structures.
Le chirurgien utilise les images 3D pour préparer avec le plus de précision possible l'intervention.
Maintenant, je dessine le contour du visage du patient et le système va essayer de corréler ce contour et tous ces points que je suis en train de faire. Et comme ça, je montre au système en espace 3D où se trouve le patient.
Une fois que les images en 3D sont associées à la position réelle du patient, voici ce que le chirurgien peut voir dans ses lunettes.
Et maintenant, j'ai toutes les structures ici devant moi. Et donc, je vois le crâne. Donc, je vois très bien les contours du volet du patient. Et donc, je sais que si je veux arriver à voir la tumeur, je dois savoir si le volet qui était déjà fait est suffisant. Et donc, si je fais Fade Skull, voilà. Maintenant, je vois que la tumeur se trouve ici devant. Fade Brain. Voilà. Et maintenant, en regardant la tumeur, je vois aussi très bien la relation avec les vaisseaux.
This is obviously something that is very nice to show, but we wanted the evidence to also back it up. So we set up some preclinical and clinical trials. The clinical trials are currently still ongoing, but for the preclinical trials, 2 of them have already been finished and I can show you the preliminary results. The first being directional drilling in the orthopedic surgery field. For this, we had 3 experience levels of people, master students, trainees, and experts, drill according to a certain pre-planned trajectory in a wooden log. And for this drilling, they had to use one of 3 guidance techniques, either blind drilling, so without any feedback, just drilling, either drilling with proprioceptive feedback in which the surgeon could put his finger at the other side of the log, feeling where the end point is, and then drilling towards his own finger. This allowed him to use his proprioceptive abilities as a feedback mechanism. And then third technique being the augmented reality guidance. And this is the result that we came up with. If we put all the performed endpoints on top of each other and we compare them to the 0 point, which is the planned and target point, we see that for the blind and the proprioceptive drilling, that there is quite a lot of variance, whereas for the augmented reality guided drilling, we see that the results are a lot more consistent. And if we put this in numbers, we see that for the augmented reality guidance, the error is almost reduced by half, and that there is a statistically significant difference to both the blind procedure and the proprioceptive procedure. What is interesting though, is that it didn't matter from which experience level you were, that the augmented reality and the added value of it was present in each experience level. Regarding whether you were a student or an expert, you would benefit from augmented reality guidance. And here we see this again. If we put it out for each experience level, we see that the augmented reality has a statistically significant improvement. And again, here we see that the variance of the results mainly comes from the AR technique, with almost a 12-fold increase in variance versus the experience variable. Then going to the second phantom trial that was completed is the intracranial drain placement. We had students without any knowledge whatsoever on how to place these drains. We had them perform the intracranial drain placement on a phantom head. The students were divided into 2 groups. One group using the freehand technique, as we do nowadays, using only anatomical references and the scans of the patient. The other group using the augmented reality guidance. Each group had to perform drain placement before any instructions, before any training on how to do this. Afterwards, we gave them a training session. And then following that, we had them place some intracranial drains again. And these are the results that we came up with. So for each group, there is an untrained performance and a trained performance. So before and after the training session. And for the freehand group, we see that the untrained performance is quite off. We can see that in white, we see the drain placed, and these are on each side the ventricular spaces in which they should end up at the same side. And we see that the drain placement in general is quite off. For the trained freehand placement, as we would expect, we see that the results are already a lot better. But if we then go to the augmented reality placement, we see that even the untrained student, without any knowledge on how to do this, but only using the augmented reality guidance, we see that they nail the intracranial drain placement immediately from the get-go. And also after the training session, it's still good. If we then scatter this, we see for the freehand placement that the result for the untrained placement is quite variable with some very big outliers. And then after training, that the performance is already a lot better. And that for the augmented reality guidance, as we would expect, we see that both for the untrained and the trained performance, that the error of deviation is quite limited. And if we then compare all of them together, we see that, as again we expected, that the freehand untrained version has quite a large error, and that this complete result is resolved after training for the freehand technique. And also for AR, the trained technique, we see that their performance is still quite good, but also for the untrained AR guidance, even at that moment, an untrained student could perform this ventricular drain placement without a lot of problems. So what are the future prospects for our study? Well, at first, there is the adaptation to HoloLens 2, which recently came out. Next to that, there's also further development of our technical aspects, putting it more on point, and also giving some more time for the clinical and also preclinical trials to complete. And also an expansion of use cases, because we feel that there is actually a lot more to be tackled with this technology, not only inside of the OR and not only neurosurgery and orthopedic surgery, but a lot more disciplines could benefit from this type of technology. So what does this technology bring as an added value for the surgeon? It means that we're looking back at the patient instead of a screen. The patient is central again. We're not looking away from the patient. With the exact anatomical overlays of a 3D model, we don't have to transpose all these 2D scans to the patient, but we can immediately see on the patient where certain structures are located. This results in a more intuitive surgery and faster learning curves. And what is required for this is really an end-to-end solution, so that the surgeon does not need to invest additional time or effort to do this, to use this technology more than he's doing it nowadays. So that's a bit my presentation in a wrap-up. I thank you for your attention. If you have any more questions or you would like to reach out to me, my mail address is at the bottom. Thank you.